So thank you, Deeku. And yes, I do love ultrasound. I see a few of the faces that came to the ultrasound workshop. So thank you for coming and doing ultrasound with us the last couple days. Today is going to be more of an overview lecture in terms of the FAST exam in trauma. How do we do it? How do we interpret it? And what does the literature show in the year 2011 in terms of CAT scan versus ultrasound, in terms of our stable versus unstable patient? So let's get right into it here. Basically, I'm going to give you a couple lecture goals. I'm going to try to keep these very short and sweet. No, there'll be no test afterwards. We'll only have two goals here. Number one, we're going to update some of the literature that we're going to go through on the extended FAST exam. And number two, we're going to look at some of the key concepts of the FAST exam in terms of actual practicing it. Okay, so what are some definitions when we talk about the trauma FAST examination? Basically, we're going to be looking into a few different parts of the human body, normally in a trauma patient. But again, those of you who are doing medical patients can also look for free fluid in the patient who may have ascites, may have SBP as a result of liver disease. It's the same examination. So basically, for our trauma FAST exam, we're going to be looking specifically into the abdominal cavity, looking for hemoperitoneum in our trauma patient. That's the first thing. We're also going to take a look up into the heart to look for hemopericardium. You need to know, does my patient have a huge blood clot sitting on the heart? Do I need to get the surgeons to come in and take that off? Do I need to do a pericardiocentesis? So we're going to look in the pericardial cavity. We're also now going to add on a couple different views onto what we traditionally call the FAST exam. Now we call it the EFAST or extended FAST. Kind of like that easy pass as you're cruising through your car, right? Going through the tolls. The EFAST examination. These are going to add on lung exams in terms of looking in addition onto the abdomen and pelvis. We're also going to look into the thoracic cavity. First of all, we're going to look for fluid, which in the trauma patient is going to be a hemothorax, may need a chest tube, has to go in. We can also add on views looking for free air. So it's actually pretty easy to look for pneumothorax. Now, how many of you all back there are doing ultrasound examinations for pneumo? Can I see some hands out there? A few of you guys, not too many on this side, some on this side. Very good. So actually, ultrasound is quite good for looking for pneumothorax, and I'll show you how to do that. Very easy examination. Okay, so let's go to some of the literature. Why should I be performing the FAST exam in patients who are coming in a traumatic situation to the emergency department? Okay, here's a very good study from, it's an older one, older but goody, September 2006, looking at 262 trauma patients, both stable and unstable groups. The researchers looked at the trauma FAST exam prior to a CAT scan, so all of these patients did get a CAT scan. What happened was, in the FAST group, which was interesting, the group that got the immediate FAST exam prior to a CAT scan had 64% less time to the operating room, meaning that those patients got to the OR quicker for definitive therapy. And you can look there and you can see the spread, 57 versus 166 minutes. So there's quite a big difference in terms of the groups. How did this all play out in terms of long-term outcomes? What's interesting is that group that got the FAST exam right up front had 27% less time in the hospital, 35% less total charges, okay, in terms of their total hospital bill. So I guess if you're President Obama trying to figure out how to slash a bunch of money from the healthcare budgets, right, what are we going to do? Well, we're going to mandate the FAST exam on all trauma patients as they come into the ER, right? Okay, we'll have to see what the Republicans and the Tea Party says about that. But we'll go on, we'll get back to that, we'll get our consensus going. Anyway, so the conclusion there was the FAST decreased the time to the OR, improved resource use, and decreased total charges to our patient. Okay, well, an article then came out afterwards making the FAST community very fast and furious. Very furious. We were pissed off. And why was that? The Canadians again. Those people who do the Cochrane collaboration, what did they do? They came up with a meta-analysis looking at all the FAST trials. They were able to find 4 randomized trials, and basically they said their conclusion, I love the Canadians, insufficient data, right, to support the use of ultrasound in blunt abdominal trauma. So thank you, Canada. We appreciate that, but you can stay up there. And now what we'll do is we'll go on to the next test, which is how to get even. Now, I know the Canadians, okay, you can come and take me down afterwards. I'll be right outside. Fine. I actually went summers up in Canada. Great place. Love it. Okay. How to get even. All right. Dr. Melniker et al. Came up with, in Critical Ultrasound Journal, a rebuttal to that, where he did his own meta-analysis. including 11 trials with a total of 2,755 patients. He found that the FAST exam had a sensitivity of 90.6% for free fluid, with a specificity of 98%, so pretty good numbers. As a prediction rule for the need for the operating room, the FAST exam actually has a sensitivity of 94% and a specificity of 98%. So actually it can be used as a decision tool in terms of which patients who are sitting in your trauma bay need to go to the OR quicker. Okay, but how does this all play out in terms of stable versus unstable patients? Well, let's look at another study looking specifically at hemodynamically stable blunt abdominal trauma patients. Retrospective review, 2,105 patients with stable hemodynamics, so stable over time. 118 of the FAST negative patients had follow-up positive CT, DPL, or laparotomy, so that meant that 118 of these patients were positive. What's interesting is, of that group that was positive, that all got a FAST exam, 37% of those had a false negative FAST group or FAST exam at the beginning of the workup. Okay, so this was done by a bunch of surgeons who said, we better take a look at these numbers. Maybe should we be doing the FAST exam on hemodynamically stable patients? And that was actually the article, the title of the article. Is it worth it? Well, okay, so that one casts some doubt on that. But we kind of know that the FAST exam works best in your unstable trauma patient. We all kind of know that that's really where we're going to be using it. And with the stable patient, we're probably going to be doing other imaging. But can we look and see what subgroup of those stable trauma patients are falling out with the FAST exam that we're missing with ultrasound? Here's another very good study by Drs. Becker et al. In the journal Injury, 2010, looking at retrospective review of 3,181 patients, all blunt abdominal trauma with stable hemodynamics. These groups were divided into 3 groups based on the ISS, or Injury Severity Score. And what's interesting, they looked at the FAST accuracy per the ISS. And what it was is that the FAST had the lowest accuracy in those patients who had the highest injury severity score. So those patients who are already like, oh my God, I think I need to get the surgeons down here and maybe we need to get a CAT scan. You're already kind of thinking that. So the FAST exam may miss out where it's going to have the less utility is in the patients who have the highest ISS. So I think then we can ask ourselves, maybe the patient who has a very low injury severity score, minor mechanism of trauma, maybe we could possibly get by with an ultrasound. Maybe we don't have to do a CAT scan on all those patients, although we need to see some more data to really make that determination. So what's the bottom line now? Year 2011, what's the bottom line? I know this course is like, what's the bottom line? I just want to know here what I can go home, tell folks in terms of the ultrasound FAST exam. Well, the bottom line is in terms of hemodynamically stable patients, your trauma surgeons continue to push the CAT scan, and the CAT scan tends to get better and better and better. There's more slices now. Before it was like 128, now it's 256. Now next it's going to be like 512, then a million slices, right? Looking through the patient. So the CAT scan is getting better, continues to have an increased role in your hemodynamically stable patient. However, a positive FAST exam in a patient who comes into the emergency department, into your trauma bay, continues to be helpful because it tells you that that patient has a possibility for decompensation. Okay? What it tells you, heads up on that patient. This patient may go south. Let me get blood up. Let me start getting my 2 lines. Let me get this patient, prioritize this patient to CAT scan sooner, and let me get my trauma surgery colleagues involved earlier in this case. Because you may have multiple casualties, and you're trying to sort out, okay, who goes to CAT scan first? The appendicitis over here, or the patient who was in an automobile accident over here. So I think it really helps in terms of up-triaging your patient. And it comes back to ATLS. I know you guys loved, and ladies, I know you love that ATLS course, right? Just one of those merit badges that we just enjoy so much doing every 5 years. But something about that golden hour of trauma, going back to the fact of doing things early in the trauma patient, getting that patient stabilized, resuscitated, the FAST exam is really going to play into that. It's going to be helpful in terms of knowing who in the golden hour of trauma do I really need to work quicker on. Okay, so that's the bottom line in the stable patient. In the unstable patient, really there's no argument. The FAST exams remains critical to the rapid identification of severe abdominal injury with significant hemorrhage, either into the chest cavity or into the abdominal cavity. It's going to be our go-to exam in our patient who's unstable, blood pressure 60 over palp, coming in to the emergency department after a car accident. Positive FAST, get your surgeons involved. Most of the time it's going to be to the OR. The other thing is now that we've added on the extended fast, looking into the chest cavity versus the abdominal cavity, now we have a better idea in terms of where the life-threatening hemorrhage is. Is it in the chest? Is it in the belly? Where do I need to focus my resuscitation efforts? Am I going to do a chest tube or call the surgeons for a laparotomy? Also, your unstable patients, remember, quicker to the OR. Now, it gets a whole other discussion. I'll have to leave that up to my trauma surgery colleagues in terms of who of the unstable group may still be a candidate for something like interventional radiology. But in general, in our minds, in terms of emergency physicians, those on the front end, it means they need to get out of your trauma bay, start moving towards a definitive procedure. Okay, unstable, positive fast, get them moving quickly. Okay, very good. With that in mind, in terms of some of the literature, how that fits in, let's go through how to perform some of the views and go through some cases as well in terms of how we would interpret it. Okay, how does the fast, on the fast exam, it's really looking for fluid flowing around in your belly. So you can imagine, if you will, just putting a catheter into a patient, emptying fluid in, and seeing where it goes. Well, there's certain definitive places within the abdominal cavity where it's going to be. And traditionally, most of the focus of the trauma fast exam has been on Morrison's pouch. Morrison's pouch really gets all the press. And in fact, when you learned your trauma fast exam, how many really focused on that right upper quadrant? I know I did. It was like, look at the right upper quadrant. We're not even going to bother with the left upper quadrant. And who cares? Do they even have a pelvis? You know? So the right upper quadrant got all the press. So there it is. Yes, the right upper quadrant is very important. But what you should realize is actually the pelvis is almost as important. And when you look at it, the main highway of fluid between the right upper quadrant and the pelvis, the 10, if you will, from those who live in Los Angeles and like to spend an hour on chocker block, traffic going home in the morning after a night shift, the freeway is the right gutter. Now, the right paracolic gutter brings most of your fluid between the lower abdomen and the upper abdomen. And so it's important to look at parts of that. I'm going to go over looking at the caudal tip of the liver as a way of getting a sense of the right paracolic gutter. Now, the pelvis is actually going to be an area where we can see a smaller amount of fluid than we can in the right upper quadrant, so we should really look into the pelvis. Also, the left upper quadrant, yes, I just kind of dissed the left upper quadrant, but we should take a look at it. It's still important. The only thing is that there are ligaments, they're phrenicocholic ligaments, ligaments that sling from the diaphragm down to the colon that prevent the free flow of fluid around into the left upper quadrant. So that can make it less of a high utility view as opposed to some of the other ones. So let's start here by taking a look at the right upper quadrant, the hepatorenal fossa, if you will, right here. Okay, so basically we're going to look at three areas in our right upper quadrant. I know you were taught Morrison's pouch, put the probe there, look for the kidney, and look for the liver, but we can do better. We can actually look above, we can look at the area right below the diaphragm, and we can look to see if the patient has pleural effusion, and we can also look in probe position 3, which you see here, which is caudal tip of the liver, looking at the beginning of the right paracolic gutter. Okay? I cannot emphasize how important the right paracolic gutter is, the caudal tip, because many times fluid is only seen there at the caudal tip before it goes into Morrison's pouch. Okay, here's how to perform the examination. You're going to want to have about a 3 megahertz. It's a lower frequency probe. You're going to place it in a long axis with the probe marker towards the patient's head. As you can see it here, we have it placed right onto the right upper quadrant. I'm up pretty high right here. You can see the probe is at a level about underneath the diaphragm. I'm just kind of showing right there that that's about the level of the diaphragm. So we want to start right there, and we can look up to see if the patient has a pleural effusion. We can look for fluid underneath the diaphragm. We're going to slide it down caudally to look through Morrison's pouch, okay? And then we're going to finish by coming even further caudal towards the patient's foot to pick up the caudal tip of the liver. Again, don't forget the caudal tip of the liver, or forget it at your peril. Okay, so this is a typical examination. This is what it's going to look like. Again, long axis view. You can see superior to the left and inferior to the right. What we have here is a nice big liver right in the middle, and we can see the kidney. Okay, so the liver and the kidney. Now, in between the liver and the kidney is going to be a potential space right there where fluid can actually build up. That's called Morrison's pouch. And you can see there that it has a little bit of a white or echogenic line that's actually fat within the capsule around the kidney. That's not free fluid. Fluid is going to look dark or anechoic in ultrasound speak, so dark. So you can see there this is a negative exam. Also, I call your attention to the superior aspect of this image here. You can see the curving white line, which is the diaphragm. Okay, the diaphragm will be moving up and down as the patient breathes, but we can also look right above the diaphragm, looking into the chest cavity. If there's fluid up there, then that's going to be a hemothorax in the trauma patient. So here's a nice negative examination. Now, it's not always possible to get the caudal tip of the liver into all of our views. You may have to move the probe sequentially down one intercostal space, as I'm doing here. I'm starting high, moving the probe inferiorly, and here we can see the caudal tip of the liver. So let's take a look there. And you can see right there is the caudal tip of the liver. And so I'll just go right here and there. Okay, and you can see that right there, you can see the kidney, and coming right below the kidney is the caudal tip of the liver. So there's the kidney, and you can see caudal tip is right there. And that's, again, we'll look for a little bit of free fluid before it goes into Morrison's pouch. So the question is, how much free fluid does it take to make a positive right upper quadrant FAST exam? I actually was kind of shocked by this, but I was a medical student out at Denver General, and I remember they were putting DPL catheters into patients at that time and putting aliquots of fluid in at the same time looking with ultrasound to see how much fluid it takes to make a positive right upper quadrant. And what's really surprising is it actually takes a lot of fluid. It can take up to 619 cc's of fluid to make a positive right upper quadrant FAST exam. And that was done sequentially by you're putting in aliquots at the same time that you had medical students looking with a probe. So that's kind of a lot of blood, right? That's kind of scary when you think about the amount of units. I mean, how much blood is in a unit of blood? 200 cc's, something like that. So that's three units of blood to make a positive FAST. So kind of scary, but again, fitting in with that use of the ultrasound in the unstable trauma patient. But maybe we can do better than the 620 by looking in alternative places, as I'm going to show you. Now, a typical positive right upper quadrant is going to look something like this. What you can see is you can see right here, the free fluid is going to be tracking right here. Mainly, it can be seen right here between the liver and the kidney. But notice here it's going to be preferentially seen around the caudal tip of the liver, okay, around the caudal tip of the liver right there, where we can actually see it really well. So let's take a look at a patient. Okay, I'll give you a scenario. This patient was in a rollover car accident, was just driving their new Ferrari in Los Angeles, going a little too far, crashed at 140 miles an hour, and blood pressure is 50 over palp. How many want to go to the OR? I see a couple in the front. How many say, let's sit on the patient and see how he does? No? How many say, let's take his car? Okay, I go with the last one, although it's going to need a lot of work. Okay, so what you see here is there's the liver, there's the kidney, and there you see a huge amount of free fluid. Okay, all that is free fluid. This is all blood in the trauma patient. And so this patient, if unstable, package for the OR. Now, what would you do if the patient's stable? Probably CAT scan, but you're going to call your trauma colleagues and say, please help, get down here. I don't know how to do that laparotomy. It was like third-year medical school that I did that last. I really don't know how to do the knife thing, so please come down and help me out. Okay, so now, this is a patient who was actually stabbed with a really, really big knife, he said, okay, and he comes in. His blood pressure was about 120 over palp. Here's the examination. Positive or negative FAST exam? How many say positive? How many say negative? You guys are right on the money here. This is subtle, right? You can see that there's only a small amount of fluid layering right there. So a subtle amount of fluid, but as I told you, it can take 600 cc's of fluid to make positive. So this is actually, that was significant. So based on this, actually his blood pressure went down after that. They took him to the OR, and unfortunately he had a liver laceration. He had basically an abdominal, he had a mesenteric intestinal injury. And so he actually had a lot of trauma going on. But that was all we saw. But based on that, we said positive. Okay, now I also told you that it's important to look again at that caudal tip of the liver to make sure that you're looking into all regions. Here's a good example of one where if you only looked here, if you only looked in the caudal tip, you would say positive or negative. You might say negative. But if you look here, definitely positive, right? So again, look at that caudal tip of the liver, and you can see liver, and you can see a lot of free fluid there, and that's not a small amount of free fluid there in that case, but you can see it's not really in Morrison's pouch. Okay, and that one I just had a really, really wide probe, but you can use a smaller probe, just move it up and down to take a look through the caudal tip. Here I'm just fanning from high down low to look at that caudal tip, and you can see there, positive or negative examination. Positive exam, as you come right down here, you can see right there, you see kidney, liver, and you can see a lot of free fluid layering right there. So a lot of free fluid on this patient, positive examination, but mainly seen at the caudal tip of the liver. Okay, left upper quadrant. Also known as the perisplenic view. We've kind of gone away from splenorenal. I have to update this, but perisplenic. We're going to look actually above the spleen for fluid. We're going to be looking mainly underneath the diaphragm, above the spleen. People also tend to think this is a mirror image of the right upper quadrant, but it's really not. The fluid flow patterns are that the fluid is going to go above the spleen and underneath the diaphragm, not between the spleen and the kidney. Here's how to perform it. Basically, you want to remember the mantra, knuckles to stretcher, knuckles to stretcher. So you want to basically hop into bed with your patient, come all the way posterior, okay? So your knuckles are all the way down posterior and you're fanning really far posterior. Again, long axis view, probe marker towards the patient's head. Here's just another view, and you can kind of see a transducer. There's the marker, and you can see we're coming in very far posterior, and we're fanning anterior posterior through that perisplenic region looking for fluid. Okay, this is a typical negative examination. Here we can see we have the spleen looking to the superior aspect. You can see there. We can see the kidney. Notice we also see the diaphragm there, that white line curving up and down as the patient breathes. And right above that, up here, is going to be the chest cavity right here. Okay, so that's where the hemothorax is going to layer out. So where does fluid layer out on the left upper quadrant? Well, it's really going to be right here, as you can see, above the spleen and underneath the diaphragm. So it's going to be really here and not in between the spleen and the kidney. The left upper quadrant is not a mirror image of the right upper quadrant. We just have to remember that. Okay, here's a positive examination. This patient was shot 4 times in the belly and the chest, and the blood pressure is 40 over palp. What do you guys think? Blood? Yeah, that's a lot of blood there. And you can see that there's a lot of blood actually right there around the spleen, in the kidney, and you can see it all the way above. So what do we do with this patient? Get a CAT scan? No. OR, absolutely. You can see a lot of free fluid there. Okay, now it may be subtle, and one of the things that can be very helpful is having the patient breathe. As they breathe, notice the diaphragm comes off the spleen, and you can actually see free fluid there where you couldn't see it before. So have the patient breathe and watch the diaphragms come off of the spleen, and there you see the free fluid there. Actually a positive examination in a patient who was initially stable but becoming unstable. Okay, the suprapubic bladder view. Now, as opposed to the upper quadrant views, which I said were long axis with the probe marker towards the patient's head, the suprapubic view, kind of like your GYN exam on your ladies, is going to be a short and a long axis view, so 2 views. Okay, and we also want to do this with a full bladder. So you want to do that examination before you put the Foley in, because your bladder is your acoustic window into the pelvis. So we mentioned that maybe we can do better in terms of that 619 cc's of fluid that takes a positive right upper quadrant. Maybe we can do better in the pelvis. So, similar study, DPL catheters going in, aliquots of fluid by medical students. Interestingly enough, 157 cc's of fluid was all it took to make a positive pelvic view. So much less than the right upper quadrant. Again, making us think maybe we really should be looking at that pelvis a little bit closer than we have been in the past, and not so much emphasis on the right upper quadrant. So just the pelvic view, potentially lower amount of free fluid. Again, I said it's a long and a short axis view. You want to do it before you put the Foley in, while the patient has a full acoustic a full bladder, basically. Here's how you do it. You're going to start first with the probe marker up towards the patient's head, kind of getting that long axis view of where is the bladder. And then what you're going to do is swivel it to the short axis, okay? And so you're going to come across, we always say, short axis should be probe marker over towards the patient's right side. So as you come over to the right, you're going to fan up and down through that pelvis. You're going to get a great view looking there for free fluid. So short and long axis views, complementary on the suprapubic pelvic view. Okay, of course, women and men are built differently down here, so we have to have a little bit of an orientation in terms of what are we looking for. In our ladies, we're going to be looking right behind the uterus here, in the potential space known as the pelvic cul-de-sac. And notice here, you're going to see it's behind the uterus, and this is where the free fluid will be found in our ladies. Over in our gentlemen, we're going to see right here behind the bladder in the retrovesical space. Okay, so you're going to be looking at different places if your patient is a man versus a woman. So just remember cul-de-sac versus retrovesical space. Here's a normal examination taken from a female, and we can see here we have quite a very large bladder there. You can see it's dark or anechoic. Right below the bladder, what do we have there? You can see the uterus there, and there's the uterus, kind of looking more like a solid structure. And the potential space is going to be right below the uterus, right there, the pelvic cul-de-sac. Positive or negative examination? Negative, no fluid there. Absolutely. Let's take a look at this one. This patient, unfortunately, fell out of a window. And so she came in, and her blood pressure is 90 over palp. So she's kind of like in between stability. You put the probe there, positive or negative exam? Positive examination, very much so. And you can see there, bladder inferiorly, uterus, and free fluid, both anterior and posterior to the uterus. Actually, so much free fluid that it's tracking out of the cul-de-sac and up and around the uterus as well. So a lot of free fluid there. If you go to short axis, what you can see is now you see the uterus and all the free fluid there, and actually now you can see the round ligaments of the uterus outlined by all the free fluid. Okay, so you got a really good view of all the anatomy of the uterus. So positive examination in a female. Now in a male, we're looking in the retrovesical space, and here we can see this is a short axis view. So we see the bladder. Behind the bladder, note we have two areas of free fluid. Okay, so a positive examination in a male. How much fluid, by the way, is this? How much do we say? 150 cc's, right, to make a positive. So that's at least 150 cc's. So we can see free fluid there. And if we turn the probe to long axis, we get something called the double wall sign, where we see fluid inside the bladder, which is effectively urine, and fluid outside the bladder, which is effectively the blood. Okay, so the double wall sign illuminating the fluid outside the bladder there. So a positive exam in a male. Okay, I'm going to just take a couple minutes here to go over some lung ultrasound. And I want to talk about the efas. First of all, looking for pleural effusions or looking for a hemothorax in your trauma patient. Basically, it's a freebie. Your probe is already there, looking up at the diaphragm. All you have to do, angle it up, and you can look and see if the patient has free fluid. We're going to be using a 3 megahertz probe, the same probe that you're using for your FAST exam, and you're going to be putting it laterally, looking up above the diaphragm, right upper quadrant, left upper quadrant. So how does it do? What does the literature show on this examination? What's interesting is that ultrasound can actually detect as little as 20 cc's of fluid, if you can believe it. Now, I guess you've got to be a pretty good ultrasonographer to see 20 cc's, but the point is that it's a lot less than a chest x-ray. A chest x-ray can take 150 cc's of fluid, especially on your supine trauma patient who's AP, where fluid is layering out posteriorly, and it can be difficult to see. So ultrasound could potentially give you a much better accuracy and pick up that free fluid way before the chest x-ray does. Okay, so what does it look like? Well, it's really best if you can have your patient sit up a little bit so the fluid's going to layer on top of the diaphragm, so you're going to be able to see it a little bit better. You can see we're having the patient sit up, and then what we're doing is we're putting the probe right about the level of the diaphragm. You can see right above the diaphragm, we just aim it up above into the chest cavity with a probe marker up towards the patient's head. This is what you're going to see. We saw this before. This is a normal examination, and what we can see here is this is a normal right upper quadrant exam, and we can see the liver, and we can see the kidney, and we can see the lung here. And notice as the patient breathes, we see the diaphragm is right there. Now, this is the potential space where we're going to be looking for free fluid. But what we see here is something that's interesting called mirror artifact. Mirror artifact is an occurrence that occurs as a result. The sound waves bounce off the diaphragm. And because the diaphragm is a hard reflector, basically it reproduces what looks like a liver inside the chest. Okay, so when you look up there and it looks like there's a liver in the chest, that's actually normal. They don't have an ectopic liver. It's okay, and that's not free fluid. Okay, so a normal examination. A free fluid or a hemothorax is going to have a dark or anechoic stripe of fluid. It's going to look slightly like this right here with a dark stripe above the diaphragm. Here's a patient who actually was stabbed to the chest, and what you're looking at is here we're looking up the right upper quadrant. Positive or negative exam? Positive. Do you guys see all this fluid right here? And what is this right here? Lung. Lung kind of is floating around in all the fluid there. So positive examination, and so easily seen by putting your probes up from the right upper quadrant view. You can see the pleural effusion. How about this one? Gunshot wound to chest. Blood pressure is 40 over palp. Look at that poor little lung just compressed down by all that fluid. And what pulmonologists call this is they call this hepatization. Because as the lung gets so compressed down by all that fluid, it takes on the look of a liver inside the chest. That poor little lung is so compressed down, it can't get any oxygen into it. So what's your next move? 40 over palp? How many want to go OR? How many want to do a chest tube? Chest tube? Couple hands up. OR? Kind of probably needs both, right? Needs, first of all, drain the chest and get the blood out, and you can actually auto-transfuse, and then you need to probably get this patient to the OR. That's a big injury there, but very positive examination. Okay, so that's the pleural effusion. I want to finish here by going over ultrasound diagnosis of pneumothorax. Now, this is kind of one of those things that we in the ultrasound community have known about for about 6 years. We learned it from a French critical care physician who kind of blew our minds at a conference that we all went to in Paris. And he's been doing this for like 25 years, but he only let on with his secret 6 years ago. But then everybody in America started just going wild with this, and now ultrasonographers are all doing it, and hopefully now you guys have heard of this. How many have not heard of ultrasound for pneumothorax? Are there any? How many have heard, I should say? A lot of you guys have heard. So it's one of those tests that's actually pretty easily done. Now, it's best done with a different probe than you're using for your FAST exam. It should be the one that you're using for your vascular access, the high-frequency probe. That's the one that you're going to use. And you want to put it in, if your patient is lying down like this, they're supine trauma patient, you want to put it where air would layer out, right anteriorly here, onto the dome of the chest. And so you can see probe position 1 here would be the optimal position to do it. Now, you can also look in a couple different areas to size up a pneumothorax, but the bottom line is if you're just trying to say yes or no, pneumo, air would collect right about here, and this is where you would preferentially see it. Okay, what does a normal lung look like? What's interesting is here's a pictorial showing a long axis view, and what we can see is a superior rib is here, so superior, inferior. We'd have a bunch of chest wall in the front here, okay? So I like to orient myself. Where's the superior rib? Where's the inferior rib? Then I'm going to look to see the pleural line. Now, the pleural line should be seen just below the ribs, and what you're going to see is the opposed in a normal lung. You're going to see the parietal and visceral pleura opposed to one another. They're going to make one shimmering line that slides back and forth as the patient breathes, okay? So you're only going to see one line. You don't see the two pleural lines. You see them stuck together, moving back and forth. You're also going to be able to appreciate these things known as comet tail artifacts, and these are these little vertical hypoechoic lines that come off the back. And we say vertical lines, always good, because if they have vertical lines, that means the lung is always up and moving back and forth. It's when you see horizontal lines that you're not sure if you have a pneumothorax, okay? But vertical lines, always good. Here's a normal examination, and we can see here we have the probe placed anteriorly there, and we're looking from rib, superior rib to inferior rib, and you can see there, do you guys see the lung sliding back and forth as the patient takes a deep breath? Do you all see that? And then do you see the comet tails, these little hypoechoic lines? Do you guys see right here? These little lines that come off the pleura are the little comet tails, the vertical lines that show you that the lung is up and that all is well in that hemithorax, okay? In that hemithorax. So this is a normal examination. So that's hopefully what you're going to be looking for, is the lung sliding, comet tails. Now, how can I document that? If I want to take a picture for history, to throw it in the Museum of Modern Art, right, for the generations to come, how would I print that out? Because if I just take a still image there, I'm not going to be able to reflect the motion. So what I can use is hit a button on my ultrasound machine that says M mode. M mode is motion mode, and if I do that, I can actually then show the motion. And what it looks like is this. If I put the M mode cursor there and I put the M mode down, I get this very relaxing sign known as waves on the beach or the seashore sign. Okay? And what it is basically you're seeing at the top there, the chest wall, you're going to see repeating lines, which are the waves, which is no motion of the chest wall, and then you're going to see the beach underneath there. And the beach is going to be the movement of the lung. So waves on the beach, normal examination showing that there was movement of the lung, no pneumothorax. So we call it waves on the beach or the seashore sign with a normal lung. Okay, so we know what normal looks like. What does abnormal look like? Well, what happens is air gets in between those two layers of the pleura, get in between the visceral and parietal pleura, making it that you're not going to see the lung sliding. Lung sliding only occurs if you have the two pleural layers are opposed to one another. Okay, so here you can see the parietal pleura is split from the visceral pleura, and there's air in between. So all we're going to see is a single white line, which is going to be that outer parietal pleura. We're not going to see the sliding, and we're not going to have comet tails. Okay, here's a patient actually who suffered a stab wound to the left chest, and we're looking there because her blood pressure was initially good, but it was getting worse. And now we're looking. How many say there's lung sliding? Anyone see sliding? How many say one line there? It looks like one line. So it looks like you can just see that parietal pleura there, and notice it's not moving back and forth. There's no lung sliding, no vertical line. So this is a positive pneumothorax, and if that patient's crashing, you might want to just go ahead and needle that chest or put a chest tube in. If they're crashing, obviously if you have time, you might get a chest x-ray, but we're talking if you don't have time, you need to get things done, then you might act just based on your ultrasound. Okay, here's a small quiz for you guys. This is just the last slide here, and small quiz. Okay, one of these chests is not like the other, okay? One of these chests suffered a large metallic object that went posteriorly into it. Okay, I'm going to put them both in play. And luckily, most patients don't have bilateral pneumothoraces. Normally, one of the lungs is up, so you can compare one versus the other. Okay, so where's the pneumothorax? Kind of like, where's Waldo? Where's the pneumothorax? Okay, how many say pneumothorax is on the right side? A couple votes over here. How many say put the chest tube in the left side? Pneumothorax on the left side. You guys are great. You guys are great. So you actually put the chest tube in the right side. So as you can see there, you don't have lung sliding right there. Notice you have a single white line. It's not moving back and forth. There's actually a pneumothorax on the left. And on this one, notice what you see is you actually see the lung sliding back and forth. And the other thing you see are those vertical lines known as comet tails. Very good. Excellent. You guys are great. Okay. And then if you just want to document the motion, you can put the M mode down. And what you're going to see is something known as the barcode sign, where you just have all the repeating white lines coming across showing no motion of chest wall, no motion of the actual lung itself.